Good morning, my name is Teresa Szyszko, and today my lecture is going to be about the evidence for performing VQ SPECT. So really this is covering the guidelines, which are the EANM guidelines, which were originally published in 2009 and then updated in 2019. And this is basically the remit of the talk. These are the areas that we'll be looking at. Guidelines can be quite dry, so I apologize in advance, but let's just go through it. So PE basically refers to venous thromboembolism. So this is nothing to do with emboli, which are septic, fat, or air emboli. This is venous thrombi, which occur in DVT and also in PE. And death can result in the acute phase or much later on through development of chronic thromboembolic disease. So as mentioned, VTE is both DVT and PE. So much of this literature was done pre the 2009 guidance. So if you have an operation of those patients, particularly orthopedics, quite a few of them, so 30% of them developed post-op DVT. Now 13% of those calf DVTs propagated more proximally up into the thigh, and of those, quite a significant number, 44%, then developed PE. So once you get a PE, your progression of PE can be quite variable. Some people can have persistent perfusion defects, and in some people it resolves very, very quickly with heparin therapy. So the literature is inconsistent here. The crude mortality rate, once you have a PE, the mortality at 3 months is 17.4%, which is quite high. And hence, imaging tests need to be carried out as soon as possible, ideally within 24 hours, obviously due to this possible rapidly changing perfusion. What's the epidemiology? Well, a third of them are unprovoked with no risk factors. The remaining 2/3 usually have a risk factor which can be temporary or persistent. And the largest risk factor here is really cancer. Other risk factors include inherited clotting disorders and temporary risks of such as trauma and surgery, as well as the contraceptive pill and HRT. The main complications once you have a PE is of thromboembolic hypertension. But you can also get recurrence of PE when you discontinue anticoagulation, and the risk is up to 30% at 10 years. So what happens when you have a clinical suspicion of PE? Well, look at the history. History is really quite non-specific. Dyspnea, chest pain, which can be usually pleuritic, tachycardia. Signs are often patients have a DVT, their blood pressure can become low, and often the investigations that they have is a chest x-ray and an ECG. And the chest x-ray is important because you have to exclude other things like pneumothorax or pneumonia. On the chest x-ray, things that indicate that you're more likely to have PE are these two findings. One is this Hampton's hump, which is this kind of peripheral wedge-shaped opacity that you see against the pleural surface. And then there's the Westermarck sign, where you get oligemia. So you have increased lung transparency distal to an occluded vessel. So clinical features of PE are also seen in patients without PE, which makes it quite hard to diagnose. So that's why you have to do these sort of pre-test clinical probability tests. And the EANM recommends using the Wells or the revised Geneva scores. There's also an indication for possibly using D-dimers. And the D-dimer is a breakdown product of fibrin clot. So these are the probability criteria as recommended by the EANM, the revised Geneva and the Wells. And so you just look at all these factors and then it tells you whether or not a PE is likely or not. Is it validated and recommended? And nowadays you just put it all into an app and it sort of tells you whether or not you've got a higher or low risk of PE. The D-dimers, as mentioned, it's a sort of a product of the fibrin clot. They are non-specific, and it varies with age. So if you're less than 50, a D-dimer of 500 is the threshold. If it's over 50, it's the D-dimer threshold. It's basically is 10 times your age. But if you've got a high probability of PE, the D-dimer has no discriminating power. You should go ahead and image. D-dimers are non-specific because it's not only elevated in venous thromboembolic disease, which PE is one. It happens in MI, it happens in CVA, it goes up in inflammation, pregnancy, and cancer. There has been there are some criteria that have been developed to try and rule out pulmonary embolism, and such criteria, as we can see on the right hand side. And if all of these are absent, the pre-test or the post-test, the probability of having a PE is extremely low. And this really can advise people whether or not they need to do the D-dimers or not. But this is something that has been looked at. So this is used to exclude PE in patients with a very low pre-test probability. So once you've got a high suspicion of PE, what imaging tests do we carry out? Well, VQ SPECT, because this is what our course is about. Previously, we used to VQ planar imaging. And in fact, this is what I learned to do. This is when SPECT was not possible, but the more updated guidelines, 2019, really just advise that we do SPECT imaging. In pregnancy, we tend to do perfusion-only scans with sort of half-dose MAA. We can now do SPECT CT with modern cameras. And the other test that we can do is, of course, a CTPA, which is readily available. The radiation dose is quite low with a VQ. It's up to sort of 1.2 to 2 millisieverts, but it's an acute disease, so we need to not delay it and go ahead with imaging. So the basic principle of diagnosing PE on VQ imaging is a mismatch where the ventilation is preserved, but the perfusion is absent. And it's interesting because why do we call it VQ? Why is it Q? Well, because it comes from the French word quantité. And it's interesting because the EANM guidance actually calls it BP, but we call it VQ. But it also exploits unique pulmonary artery segmental anatomy because the perfusion is of an area corresponding to an occluded end artery. So what are the imaging agents that we can use? So for the perfusion aspect, we tend to use MAA. This is human microalbumin particles, and patients are injected and scanned in a supine position. And normally you use 400,000 particles. So a small fraction of those obstruct pulmonary vessels. That's how you get your image of lack of perfusion. When you have patients with pulmonary hypertension, you need to decrease that to at least half dose usually, and we also decrease the dose administered to children by weight. So that's for the perfusion aspect of imaging. In terms of the ventilation, we can use technetium-based aerosols, so we've got DTPA, but more commonly, most people use Technigas. These are usually administered with the patient in an upright position. We can also use krypton gas. If you use krypton gas, the patient is scanned using the supine position. And the kind of thing that you notice with using kryptons that you don't see with the other agents is that you get uptake in the trachea. So this uptake in the trachea usually indicates that your ventilation agent is krypton. I won't go on about this too much because there'll be lots of other interesting lectures, but these are just the imaging agents. Now, historically, to diagnose PE, looking at mismatched perfusion defects with preserved ventilation, it used to be based on probability. And there was a huge indeterminate rate, which is why this wasn't particularly great. So the original criteria were PIAPED, In 1990, then they were revised, and then you had PIAPED 2, then you had modified PIAPED. These are all historical, and if you're interested, this is basically a summary of these probability-based criteria. So the current criteria are not probability-based. The EANM 2009 criteria is what we still use today, and it's about looking at mismatch in at least one segmental or two subsegmental regions that conform to pulmonary vascular anatomy. The VQ SPECT has higher sensitivity and specificity than planar imaging, and therefore it's more accurate. It can be also used when patients have coexistent COPD or pneumonia, and it has a very low non-diagnostic rate. It is not probability based. And these are the criteria. So for a PE, as mentioned, and as I said in the EANM guidelines, they call it VP, not VQ, you need to have a mismatch of at least one segment or two subsegmental defects. If you've got one subsegmental defect, that is not a PE. If you've got multiple defects, again, if you've got widespread abnormalities, not typical, then again, you may have a non-diagnostic study. But yeah, you need at least one segment or two subsegmental defects. And if you've got mismatch, but the opposite way, that's not a PE. Why did we choose the VQ SPECT imaging over the planar? Well, there's no overlapping structures. You can clearly see all the segments, but much better visualization of the anatomy. And the specificity and sensitivity is very high, as well as a negative predictive value. It's a very low indeterminate or non-diagnostic rate, and it's good intra-observer reproducibility. So this is a traditional VQ scan, which planar image, which shows that there is these were the sort of 8 projections that you normally have in a planar image. And here we've got a defect here on perfusion imaging, and you've got it's preserved ventilation. So this is a PE, all-star planar imaging. And this is the current SPECT imaging. Actually, this was in the same patient before. You can see it's much more extensive, the defect. So yeah, this is the defect in perfusion with preserved ventilation, and we can see that there are further perfusion defects. The quotient imaging, which we'll see on the next slide, it's better displayed, is basically subtraction or looking for the difference between the two imaging. So this is much easier seen in colour. So here we've got the ventilation images, which all the ventilation is preserved, but here we've got several areas where there's missing perfusion, and the quotient imaging basically shows you where you've got, like here, where you've got the sort of mismatch between the ventilation and perfusion images. So looking at segmental anatomies, there's this really nice diagram in the guidelines. It just tells you about all the lobes and the names of all the lobes. And actually, when you're reporting VQ, it's quite nice to have this so that you can check for the segmental anatomy to make sure that you've got segmental or subsegmental defect. I think this one's, I've stolen this from Radiopedia, but this is actually in the EANM guidelines. And again, these are the criteria for if you've got mismatch, if you've got one segment or two subsegmental defects, this is a PE. If you've got one subsegmental defect, this is not a PE. If you've got matched defects, it probably is more likely that this is atelectasis or empyema. If you've got a reverse mismatch, it could be related to COPD or pneumonia. There's this thing called the stripe sign, and this is preserved perfusion along the pleural border, and this is a specific sign for pneumonia. And this is just to see what it looks like. You've got the stripe on the perfusion imaging along the pleura here. So this is seen in pneumonia. It's just because it's quite rare, and it's just us to show you what it looks like. So VQ mismatch is not always or exclusively caused by PE. There are other conditions that can cause it, including vasculitis or congenital abnormalities, which can be a pitfall of it. But yeah, it's just to be aware. Other pitfalls are hotspots, and this is what they look like. And this is caused by MAA clumping. And normally when you're injecting, you sort of, when the technologist is injecting the MAA, you can just pull back on the syringe and then inject. If it mixes with the blood, you can get blood contamination, and you get this clumping effect. Other pitfalls are that the ventilation agent, particularly technic gas, which is used in COPD, can get trapped within the bully. So you've got absent perfusion, but the ventilation gets trapped in the bully. So it looks like a mismatch, but it's not. Apart from that, you can get non-segmental defects due to fissures and various other things. You can get segmental defects related to vasculitis. And the other thing I've noticed that if you, for example, do the perfusion and the ventilation on different days, sometimes if you've got like a difficult scan and a pregnant patient, they can be in different positions or at different time points, so they may not be as easily comparable, and that causes problems too. So these are the pitfalls. In terms of follow-up, so PE can be a single event, but it can be a recurring process. And it's useful to be able to sort of follow up to see if therapy is effective, and to differentiate between old and new PEs. And VQ SPECT is really, really good for this. So this is, again, an example in the guidelines where patients got a defect, and then it gets worse, and this is when it gets treated. So yeah, this is just a sort of progression of PE. You can get chronic PE, and this is a distinct entity. And this was, I mean, very interesting. So that was carried out at Imperial, actually, when I was a registrar, back in the old days. And so Nina Tenario looked at VQs and CTs in chronic PEs, and VQ was much better for assessing chronic PEs. And chronic PEs is important because you get sort of right heart issues, and you get quite significant morbidity and mortality related to this process. Just a few words then about COPD, the reverse mismatch. So this is where you've got a ventilation defect but preserved perfusion. So in COPD bully, you get mismatched, so you get preserved ventilation, and there are different gradings. And if it's naught, it's normal. In 1, when you've got mild defects in terms of the ventilation but preserved perfusion. Then as it sort of goes on, you get more moderate defects, and then some perfusion abnormalities, and then you get severe and predominantly peripheral issues, and you get major areas of reduced function. So it's only the central area that's okay. So this is COPD. This is just for interest. So as mentioned previously, we now have the capability on many cameras to do CT as well as carrying out the VQ SPECT. And the CT is usually carried out in shallow breathing in the same sort of way that we do in PET imaging, and it's a low dose CT without contrast. The additional radiation dose in the CT is 1 to 2 millisieverts, so the whole procedure is up to sort of 4 millisieverts. It's got a similar sensitivity to VQ SPECT, but slightly higher specificity. You can use CT instead of the ventilation imaging, but that's not ideal. But it's quite useful to see things which are not thromboembolic, such as empyemas, pneumonias, or if you've got extrinsic vascular compression. And this is the example from the E&M guidelines. Again, this is where we see that you've got perfusion and ventilation imaging, and the perfusion follows the ventilation, and you've got matched ventilation and perfusion defects. So here we've got the green arrows. So this is matched defects, and this is emphysema that we're seeing. And then we've got a further matched defect here within the sort of right mediastinum, and this is actually a tumour. So in COPD, you have added value of VQ SPECT, because we can see that there's a tumour sitting there. So as I mentioned, these E&M guidelines were published in 2019, and then sort of COVID hit, and people have done a bit of work looking at there were some publications looking at SPECT CT with COVID, and just looking at these right-hand side images. I think there was an issue obviously with the ventilation aspect in COVID, and often you would normally do the ventilation first and then the perfusion, but people stopped doing the ventilation. And so this is an example where the workflow was modified. In this case, the perfusion was performed first, and this showed a defect. Then they did go on to, because they saw a defect, they did go on to do the ventilation, and this was preserved. And a CT scan, low dose CT, summarizes that there were no structural abnormalities here caused by COVID or anything else really. So this is just an example of how workflow changed in COVID in VQ imaging. Another study more recently published, actually this was published last year, also in JNM, and this shows very nicely how perfusion defect actually corresponds, as the patient who's recovered post-COVID. There is a diffusion defect, but it actually corresponds on CT for an area of mosaic hypoattenuation. So this is kind of uses of CT. So a few words about CTPA. So obviously CTPA is readily available 24/7, very high positive predictive value. It's also useful for looking at other pathology, but you can't use CTPA if you've got iodine hypersensitivity, although actual allergic reactions are actually quite rare, but anyway. Thyroid dysfunction, you can get induction of hyperthyroidism. Renal dysfunction, certainly, and renal dysfunction is where you get the rise in creatinine within 48 hours to 72 hours. And we look at the GFR cutoff. It depends on your institution, and there are several publications. Some places say less than 60, some places less than 40, some places even say less than 30. And the other indication is in pregnancy, where there's actually a very significant breast dose from CTPA, so it's better to do a VQ scan. So this is colleagues in Bath. This is some of the doses that the doses, but effective doses they've had, like and breast dose from CTPA and VQ imaging, and we can clearly see that the breast dose is much higher on CTPA than on VQ imaging. There are some other problems with the CTPA, and one is that you actually, to get really good quality scan, you need a really high Hounsfield unit. You have to hit 2010, some institutions even higher. So you need adequate pacification. Obviously, the breast dose we've already mentioned. You can have respiratory artifacts, but it is available 24/7. It's very quick and it's cheap. Again, breast dose, and you may get inadequate because of the increased circulation. You may get reduced opacification of the pulmonary arteries, and sort of problems with indeterminate scans. So these are pros and cons of each of these methods of VQ versus CTPA. So effective dose, usually a bit lower in VQ than CTPA, but absorbed breast dose is significantly reduced. And this is actually another part of the ELN guideline, said that actually the breast dose is less than 1 millisievert. Interestingly, fetal dose is very small and similar in both. So again, this was a comparative study that was performed by our colleagues in Bath, who are kindly joining us on this course. And it just summarizes the advantages of each, in that, you know, VQ is great in renal impairment. It's sensitive. It can be used in pregnancy, and also sort of there's in patients with contrast allergy. But CTPA is quite useful for looking for other diagnoses and has got increased accuracy in COPD. But as mentioned, you can do VQ SPECT CT. And again, these are some of the data on sensitivity, specificity, and accuracy. just to mention a little bit more details about pregnancy. Risk of PE in pregnancy, I was quite astounded to find, is 5 times higher than in a non-pregnant female similar age, and it's quite actually shocked me that it was that high. But the incidence is also similar in all 3 trimesters. The D-dimer is not useful because it's elevated. CT has the unique hazard of dose to maternal breast, and the EANM guidelines actually recommend perfusion-only scintigraphy in the first 3 months of pregnancy. Many institutions use it throughout pregnancy. Most people tend to use a half-dose perfusion imaging as well, but the EANM guidelines specifically just talk about perfusion only in the first 3 months. And this is their algorithm for performing VQ SPECT imaging, and that is ideally VQ SPECT, but if it's not available, you can get away with planar because not everyone has a machine that's capable of doing SPECT, or CTPA. If you've got a negative CTPA, you may need further tests, but you have you really have a VQ planar scans, you may get a high indeterminate rate, and then you can need to go on and do a CTPA. But VQ SPECT is got a very good performance. This is the pathway that we use in Royal Free, and we do discriminate somewhat on age. And that sort of the older patients tend to get a CTPA. Younger patients or pregnant, depending whether or not they have a normal or abnormal chest X-ray, we then perform VQ imaging, again half dose if pregnant or postpartum, in fact. Whereas if they have an allergy or renal impairment, we proceed with a normal dose. And with our COVID positive patients, we did tend to also perform the CT as well, because it would help with interpreting the data. So this is a summary of the guidelines. Imaging tests should be carried out as soon as possible, ideally within 24 hours. You can rediscriminate who goes on to having VQ or CTPA imaging. We are using the prediction models and biomarkers, namely sort of D-dimer, and they help to sort of stratify the risk. And that's all now available in an app. A VQ SPECT is certainly more sensitive and specific than VQ planar imaging, with a very low false negative. And it's got similar accuracy to CTPA for PE diagnosis. Despite the advances in CT and its availability 24/7, there is still a role for VQ in pregnant patients, and you would use a half dose usually for pregnant patients, particularly because you give you a lower breast dose and but similar fetal dose. Patients with renal impairment and contrast allergy should go on to have VQ imaging, and younger patients. The main complications from PE are that you can get chronic thromboembolic pulmonary hypertension, right heart failure, and sequelae. But there are other causes of VQ mismatch, things like vasculitis, which are not just PE. And VQ SPECT CT is useful in COPD and also in COVID. Thank you very much for listening, and thank you very much for some of the lecture slides from the Bath group, particularly Professor Graham and Dr. Redmond.